Hello, and welcome to the 48th Annual AAKP National Patient Meeting. Transforming American Kidney Health. Patients take the lead. I am Dale Rogers, a resident of Idaho who has been fortunate enough to receive 2 kidney transplants and a pancreas. Furthermore, I am honored to hold the officer position of Secretary for the AAKP. Since struggling with type 1 diabetes for 43 plus years of my life, along with the hardships of kidney disease, I understand the importance of patient voice, patient choice, and the connection needed between patient, doctor, and science to improve life. Being an AAKP board member and an ambassador has allowed me the opportunity to vocalize some of my personal hardships and the hardships of many patients I stand alongside. I've had opportunities to speak with our Congress men and women about policy changes and funding of science during the many AAKP Hill Days I've attended. I stand firm with AAKP and proudly represent AAKP's core mission and principles as I sit around tables with the National Institute of Health, the Food and Drug Administration, and pharma companies regarding various projects and initiatives, making sure the real patient voice is heard while plans are being made to improve our lives is a shared goal I have with AAKP. As a member of the organization, I share the message that every kidney patient has the most important voice in determining their care plan. It is imperative that an environment is created that supports kidney disease research and innovation so that we are continually advancing care, improving treatments, and providing solutions for unmet patient needs. And when those innovations are FDA approved, it's critical that all patients have access and the right to choose the treatment to in consultation with their doctor. They choose to care for them. That is right for them. So every patient can live their best life and achieve their aspirations. And with that, I am pleased to introduce our next session titled Metabolite Found in Urine Predicts Kidney Failure from Type 2 Diabetes 5 to 10 years early. I am delighted to introduce Dr. Sharma from Texas. Dr. Sharma's groundbreaking research focuses on unraveling the intricate mechanisms and advancing the treatment of diabetic nephropathy. His expertise has garnered him several research grants, including funding from the National Institute of Health, the National Institute of Diabetes and Digestive and Kidney Disease, and the Juvenile Diabetes Research Foundation. Furthermore, he has actively contributed to the scientific community of serving on numerous NIH study sections and holds a standing membership in the NIH Pathology of Kidney Disease Study sections. It's my pleasure to hand the presentation over to Dr. Sharma.
Hello, I'm Kumar Sharma at UT Health San Antonio, and I'd like to thank the organizers of AAKP and Dale for inviting me to the 48th annual AAKP conference. And I'll be talking to you today about new data on the early prediction of diabetic kidney failure. These are my disclosures, and they're not relevant for today's talk. Diabetic kidney disease is the #1 cause of kidney failure, and approximately 1 in 3 adults with diabetes will ultimately get some degree of kidney disease. And high blood pressure is close behind, and 1 in 5 adults with hypertension or high blood pressure may also develop chronic kidney disease. Patients who develop kidney failure are at high risk of complications, and the annual Medicare cost for kidney care is over $75 billion for the United States. And unfortunately, this accounts for the budget for all of NIH, NASA, and the Department of Energy, but very little is spent on preventing kidney disease and finding new cures for kidney disease progression. What does kidney disease look like if you take a biopsy of the kidney in a patient with diabetes? Classically, the picture on the left shows a picture of a patient with diabetic nephropathy where they have expansion of this regions in the glomerulus, which is called the mesangial matrix. There's also a lot of disease outside the glomerulus in the tubulointerstitial region and the vascular region, but we don't know what is driving this process. As opposed to the classical picture of diabetic nephropathy, somebody with hypertensive nephropathy on the right side had a different distribution with less glomerular disease and more tubulointerstitial and vascular disease. And we don't know what the drivers of these disease processes are. So if we can identify biomarkers or markers that are linked to the progression of the pathology, that's likely to be associated with identifying why these patients develop kidney disease and hopefully catch them earlier in the process. The current situation is that we only have one marker for identifying patients who might get kidney failure in the future, and that's if they leak protein or albumin in the urine. Unfortunately, this is not applicable to all patients with diabetes who ultimately get kidney failure. As is shown here in the largest natural history study of diabetic kidney disease in the United States, which is called the CRIC study, we could see that if a patient who has a lot of protein in their urine, be it greater than a gram or 300 milligram per day, are at very high risk of developing kidney failure. And we know how to identify these patients. However, patients with lower levels of protein in their urine and even normal levels of protein in their urine can still develop kidney failure. And although they're at lower risk, if you happen to be one of these patients, getting kidney failure still puts you at very high risk of developing complications and needing dialysis. So regardless of the category you fall into, you would want to know if you are going to be destined to develop kidney failure and what you could do about it in an early stage. The recognition that patients without proteinuria can still develop chronic kidney disease is not very well known in the literature and even among medical practitioners. So in several studies over the past 10 to 15 years, we've recognized that up to 20 to 30% of patients who develop kidney failure and kidney disease may never have albuminuria. And if you break it down to those without any albuminuria at all, or even slight amount of albuminuria, this may even be over 50% of patients who have diabetes and develop chronic kidney disease without a lot of protein in their urine. And that really is not well known among most physicians and patients, unfortunately. So how do we address this problem? How can we find new ways of identifying markers that predict patients will have kidney failure even if they don't have much protein in their urine. And the field of medicine and biology is undergoing a revolution right now with the availability of a lot of new tools and the use of a lot of multi-omic technologies. So we can now identify all of the gene transcripts in a cell. We can identify a lot of the proteins in a cell, and we can also identify metabolites in a cell. And our group in particular is focused on looking at the metabolites because we think that those are very important to actually drive the disease process, as opposed to the genes and proteins, which may put you at increased risk, but often we don't know if that has functional meaning if the transcripts or the proteins change. But when the metabolites change, that usually indicates that there is a functional effect and a direct effect in causing pathology. Metabolites are very interesting and often aren't considered to be critical to understanding a disease process. But these are the small molecules that are produced by the body as a result of metabolism. And these molecules can serve very important roles and indicators of the body's metabolic activities and health status. Not only do they play a role in cell function, but they can also be involved in deciding whether a cell is taking a healthy pattern or a disease pattern. And they can also be used as biomarkers that can be measured in the blood and the urine, as well as being measured in the cells themselves. We focused on looking at metabolites by several approaches. Several years ago, we started a large study of measuring over 6,000 metabolites in the urine with a tool called untargeted metabolomics, and we measured over 1,000 patients who went on to develop some degree of kidney disease and had diabetes and had some degree of kidney disease at the time of the measurement. Using the study, we found on the left-hand side a panel of about 15 metabolites that were associated statistically with a higher risk of kidney failure. And this was with an untargeted approach where we measured over 6,000 molecules. We then went on to verify that this was true using a targeted metabolite approach where we can quantitatively measure each of these metabolites. But the challenge is to figure out which of these molecules should we go after. So of these 15, which are the most important to study? What we just did was a technique called bulk metabolomics, which measures all of these molecules in the blood, urine, and could be measured in the tissue. But by measuring it in bulk, we lose the tissue microarchitecture, or where is the pathology in the kidney in this example. So we don't really know if the molecule that we're measuring is causative or an innocent bystander of the disease process. So what is missing is a method to know which metabolite specifically might cause the disease. So what we really want to know is to map the metabolites in the tissue of interest, and in this case it's the kidney, and to know if the metabolites are associated with the pathology. So we are part of the Kidney Precision Medicine Project. This is an initiative started by the NIH about 6 years ago. And what we're doing is to take kidney biopsies of patients with diabetes and hypertension that's causing kidney disease, and to look at these new omic tools with that kidney biopsy from patients. And so we're part of a large consortium where transcriptomics are measured, proteins are measured, and our group in particular is measuring metabolites in the kidney tissue. What's different about our approach is that we look at the tissue microarchitecture. So the kidney tissue is not homogenized, but we maintain the structure, the architecture of the kidney. So we can see the glomeruli, we can see the tubules, and we can see the blood vessels, and we map the metabolites onto that tissue. And so we can link the metabolites to the normal parts of the kidney as well as the abnormal parts of the kidney using this technique called spatial metabolomics. Using this technology, we can see by a fluorescent technique where are the different features of the kidney biopsy. And this is shown here from a human kidney biopsy, which is called a core, and then label the metabolites by using a mass spec approach and seeing where these metabolites are falling in the part of the kidney. And then with an overlay technique with other methods such as a PAS image, we can get a better picture of where the normal parts and the abnormal parts of the kidney are. So with this method, we made a very interesting discovery. We found that a specific molecule called adenine is localized to the regions of pathology in the kidney. So this is the kidney biopsy of a human patient. These are normal tubular cells, and these are abnormal tubules, which are atrophied and very small. And there's scarring here, as well as interstitial fibrosis. It's also adjacent to scarred blood vessels called arteriosclerosis. And in these regions of pathology is where this molecule adenine lights up. And so we see adenine next to the atrophic tubules, next to the sclerotic blood vessels, and even present in some areas in the glomeruli where there's beginning of what's called glomerulosclerosis. So with this spatial technology, we identified that one particular molecule, adenine, is associated with the pathology. And so we focused on this molecule, adenine, and then we went on to look at several normal and patients with diabetic kidney disease. And we found that those patients who have a normal kidney biopsy in a healthy individual has a very little level of adenine and is present in the biopsy. However, the patient with diabetes has a lot of adenine throughout the kidney biopsy, but it's most intense in the area of pathology next to the sclerotic artery and the atrophic tubules. And this is a quantitative level showing that there's increased adenine in the diabetic kidney. And most of these patients did not have proteinuria and had a normal GFR at the time of the biopsy. Now, is adenine a cause of kidney disease? And we think it is in humans because adenine is associated with other molecules that's known to be associated with kidney failure, such as uric acid. And in some rare patients who have a mutation in a gene that converts adenine to AMP, these patients develop kidney failure. So there are several examples that adenine itself is causing kidney disease in patients. And our study is the first to show that endogenous adenine in patients with diabetes could be a cause of kidney disease. To demonstrate that and to prove this idea, we did a mouse study where we gave adenine to normal mice and we stimulated the molecules that's known to cause kidney injury, such as a molecule called KIM1 and another molecule that's known to be associated with kidney failure and diabetes, which is the soluble TNF receptor. And this is true not only in the kidney, but also in the blood. So this suggests very strongly that adenine could be driving these other injury markers of kidney disease. And adenine may be causing kidney disease by a pathway called mTOR. This is a pathway that's known to cause scarring and fibrosis in multiple models of kidney disease, but our group is the first to identify that adenine stimulates mTOR in the kidney and could lead to kidney scarring. So to see if this is true in patients, we developed a new assay, which is to measure urine adenine in patients with diabetes. And we found in the CRIC study with over 900 patients that those people with high levels of adenine were the ones that were at high risk of developing kidney failure or having mortality within a span of 5 to 10 years. In addition, we went to another study in Singapore, and we found that in Singapore, with a different ethnic population, which included Asian Indians, Chinese, and Malays, again, the group with the high level of urine adenine were the ones that developed kidney failure or had all-cause mortality 5 to 10 years later. So our study has now demonstrated that adenine molecule is found around scarred blood vessels and kidney tubules, and it is associated with kidney damage and all-cause mortality. The study involves over 1,200 patients and is consistent across diverse ethnic populations. Furthermore, blocking adenine blocks progression of kidney disease. So we were able to identify a small molecule called mTDIA that blocks adenine production in a model of diabetic kidney disease. It lowers the albuminuria, lowers the creatinine level, and lowers serum cystatin C, which is all beneficial to block the progression of kidney disease. So this suggests that there could be a new therapy associated with adenine production, as well as to identify these patients at an early stage. The study is now published in the JCI and coming out next month in October of 2023. So what is the implication of this work? We could say now that measuring the urine adenine creatinine ratio in patients even without proteinuria could identify those that could be at high risk of kidney failure 5 to 10 years later. We also found in the study that urine adenine levels could measure benefit in patients started on a drug called an SGLT2 inhibitor. And finally, new therapeutics that block adenine specifically could benefit patients with progressive kidney disease, even if the SGLT2 inhibitor fails to block kidney disease progression. The study has identified that patients with diabetes may still get kidney failure even if they don't have much protein in their urine. And now we could identify those patients and pick them up fairly early so they could benefit from therapy. I'd like to acknowledge all of the members of our lab at the Center for Precision Medicine at UT Health San Antonio and our many collaborators throughout the country and all of the members of the Kidney Precision Medicine Initiative and funding from the NIH, JDRF, NASA, and the Veterans Administration. Without their support, this work would not be possible. Finally, I'd like to introduce you to this concept of precision medicine and what our group, as well as many others throughout the country, are using new markers to identify potential pathways that are linking the patients to a pathway that can identify whether they are at risk of developing complications of kidney failure. And by knowing those markers, we can then link new therapies or existing therapies precisely for that individual. And this is called precision medicine. And we think that this is going to be an important way to identify patients at an early stage of diabetic kidney disease and give them the treatments they need to block kidney failure progression. Thank you very much. And it's a pleasure to be part of this conference. And I wish everyone to have a great day.
Thank you, Dr. Sharma, for an excellent presentation and insightful look into your research. Your work continues to pave the way for groundbreaking advancements in the understanding and the treatment of diabetic nephropathy.